Welcome, everybody. Cinco de Mayo, and of course, it's official Red Dress Day in recognition of Indigenous women and children. And so hopefully you're all wearing your red. I didn't have mine with me, so but just to acknowledge that. So today's Grand Rounds, before we begin, I would like to respectfully acknowledge that we're located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. And just keeping Red Dress Day in mind. So I'm really excited about today's topic, and I want to give a shout out to Karen Doucette, who had actually heard Dr. Fabreau speak at an ID meeting and recommended this presentation. So really excited. So I'll just go ahead and get started introducing, first of all, Dr. Fabreau is an assistant professor in the Department of Medicine and Community Health Sciences at the University of Calgary. He co-founded and co-directs Refugee Health YYC, a research, education, and innovation platform focused on the health and healthcare of recently resettled refugees and asylum seekers in Canada at the O'Brien Institute for Public Health. Clinically, he cares for recently arrived refugees in Calgary as an embedded specialist at the Mosaic Refugee Health Clinic and as an inpatient physician at the Peter Lougheed Center. Dr. Fabreau completed his medical training in internal medicine in Calgary, academic fellowship in GIM at Harvard Medical School in the Brigham and Women's Hospital, and a Master of Public Health at the Harvard School of Public Health. His interests include health services and public health research, with a particular focus on refugee health and high-needs socially vulnerable populations. And then Dr. Molly Whalen-Brown is a family physician who provides primary care services to refugees at the New Canadians Health Centre, where she also serves as the medical director. She also has a focused reproductive and sexual health practice and practices remote family medicine in the Northwest Territories. She's the program director for the Health Equity Enhanced Skills Program at the University of Calgary and is also the domain lead for health equity in the family medicine program at the University of Calgary. So I'll hand it over to them with the title of Refugee Health and Healthcare in Canada and Alberta Perspective.
Okay, thank you very much for the introduction and for everyone's time and the invitation. This is a first for me doing Grand Rounds at someone else's university. So thank you for the first. If there was a bucket list, it's officially now crossed off. I grew up in Medicine Hat, so I don't believe in Calgary, Edmonton hate fest like my wife does, who's from Calgary. And I have a lot of friends at U of A, and particularly at the Alex. So thank you very much for the invitation. All right. I study refugee health, so I never really have any disclosures. I'm always looking for some, but it's not a lucrative research area. Our agenda, we'll try to go quickly so we have lots of time. We're going to do an overview of refugee health and refugee populations. We'll talk how refugee health and asylum claimants, we'll just use the same term for both categories, receive medical care in Canada. We'll review some common resettlement issues that really impact how we deliver care. We'll talk specifically about Alberta, given where we are. And then for the trainees, if you're out there, we've cut out the boring research stuff, and we put a bunch of good cases for you. Medical jeopardy always is a winner for us in internal medicine. And then at the end, we'll add some resources. And I'm also really happy that Dr. Whalen-Brown, who was with us in Calgary, now the medical lead in Edmonton. So the resources, the hope is to actually provide resources that are really specific to you folks in Edmonton. And we're always trying to do a better job of integrating what we do out in the world, out in the community with our hospital colleagues. All right. So I don't really like the term migration crisis, but it gets overused. But certainly we have a problem globally, and it's predicted to get worse. Over the last decade, the population of people that have been forcibly displaced to leave their homes for a variety of reasons has increased every single year for the last decade, and every single year has reached new records, new heights. And this is most recently, I guess now Sudan, we can add Sudan to the list of countries that unexpectedly are producing refugees. But the two in Canada that we've been dealing with the most in the last year have been the Ukraine emergency, with 8 million refugees within less than a year being produced, and 7 million internally displaced. And then Afghanistan has been, unfortunately and tragically, perpetually in crisis, but since August of last year, another mass exodus. So oftentimes people interchange refugee with immigrant and migrant, and there's a bunch of different terminology used for different reasons. So I find it useful to just start from the beginning. So I apologize if this is basics, but the word migrant gets used a lot, and the International Organization of Migration, that is an official terminology. Migrants are people that move out, they leave their country. But there's two big categories. There's the voluntary, so that's what we would consider immigrants, and they generally make up 80–85% of the immigrants that become permanent residents. In Canada, we also have, so under the immigrant category, we have economic class, we have business class, we have family reunification. We also have now increasing population of temporary migrants, which would include temporary migrant workers that come seasonally, or international students. But we really focus on the forced migration. And so forced migration are people who do not want to leave, have no plan to leave, have no intention of leaving their home, but are forced to for a variety of reasons. Oftentimes it's war, famine, disruption, political persecution, you name it. And then this gets broken down into two categories. So we have asylum seekers, or in Canada, we call them refugee claimants. And those are folks that come to Canada. So if you've seen anything in the news about Roxham Road from last month, those are folks that come to Canada, however they can get here. And once they get to Canada, they avail themselves to the Canadian Border Services Agency or other officials at the border and say, I'd like to claim asylum. And those folks are then granted, they go through the process of being granted a hearing. And historically, about 50–60% of those that claim asylum are granted asylum, become permanent residents in Canada. The other category, which is when we call refugees, we call them convention refugees in Canada. And that convention is the Geneva Convention that you hear about in the movies after World War II. And it was updated to the Convention of Refugees in 1951, of which Canada is one of the original signatories. And convention refugees in Canada have two categories. So there's the government assisted refugees and then privately sponsored refugees. So government assisted, our federal government does the sponsorship, bring them to Canada. We receive lists from the UNHCR, and we choose refugees off of the very long list that the UN provides to Canada. And we are the country that invented the privately sponsored refugee model. It's actually been in Canada for over 40 years and very successful, in fact. And so it's been exported. Recently, the Americans started. We always love these stories, things we invent and export to the US. So the Americans have recently imported, and some European countries, but the Americans in the last 2 years have started a privately sponsored ship model. And that's where institutions, churches, or groups of 5 people can sponsor a refugee, come to Canada, and then are financially obligated to assist the family or whoever they bring for a year. Okay, so what is the actual definition? This was written in the original Geneva Convention, and then again in 1951. It's a person who's owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, or political opinion that is outside their country of nationality, and is unable to, or owing to such fear, unwilling to avail themselves to the protection of that original country. So in Canada, anyone who is a convention refugee has a 100% acceptance rate. They're generally accepted prior to coming. And then the moment they hit, this changed after the Syrian refugee influx, the moment they hit Canadian soil, they are a permanent resident. The refugee claimants, and this number has changed. It was lower in the past, but now we're about 50–60%. Those are people that come. It's a long process. It takes sometimes up to 2 years on average. And then about 50 to 60% of those folks are accepted as claimants. Now, since the Ukraine crisis, now we have a whole third category, which our government is calling evacuees. The Ukrainian nationals that have come are 100% fit the definition of the Geneva Convention, but we call them evacuees simply because of they've been given, there's a separate temporary residency program that the government has initiated since the war, and it has its pros and cons, but by definition, they are refugees. We call them evacuees because they actually are in a different bureaucratic category. So one of the things that, in 2019, Canada was the most resettling country in the world. We're second in the world only after the Americans because of volumes. We've resettled well over 1.5 million people or more since 1957, which was what we think the start of the modern era of resettlement. One of the issues is, the grand majority. So in the black bar is the proportion of forcibly displaced refugees, just refugees, that are resettled to high-income countries. And there's 26 high-income countries. We're always in the top 2 resettling, sometimes 3. And you can see that over time, this bar never really moves very high. It did a little bit over the Syrian refugee or the Syrian crisis and the civil war there, and dropped off during COVID, but less than 2% on average of forcibly displaced refugees in the globe are actually resettled each year. 95 to 98% are displaced in countries adjacent to the wherever the conflict is. So for example, if you look at Afghanistan, 90% of the refugees are in Iran or in Pakistan, and have been, or in the case of Ukraine, Poland and surrounding countries. Oftentimes those countries are in the global south and are economically deprived. And so the grand majority of the burden of refugee care is actually in middle and low income countries. So before we applaud ourselves too much, what we do is important, but we are a small proportion of the black bar. Okay, so last year, 2022 was actually, I think, the most ever, the highest number of resettled refugees in Canada for many years. So it was about 75,000 in 2022 alone. You can see this is the last time a nice little bar chart was made, and you can see orange is government sponsored, gray is privately sponsored, and blue is this blended program. But it really dropped off during COVID. It has increased dramatically since the post-COVID era. And we have 2 active programs, the Afghan Resettlement Initiative and Ukrainian Initiative. And so in 2022, about 17.2% about is the exact number of new permanent residents in the country, in Canada, they're actually refugees. And generally that number is much smaller. It's about 10% or so. So since August 2022, these are our 2 biggest programs. We have welcomed 30,000 Afghan refugees. Calgary is the Western hub for the country, and then we distribute. The goal was 40,000. But if you look at the Ukrainian evacuees, which I will just refer to as refugees, those numbers are astounding. So we've had over 208,000 Ukrainian nationals arrive to Canada. Some are Canadians with permanent residency that have come back. And Canadian government's received about 1 million applications and has approved 665,000 applications. And that program, it's a 3-year temporary work permit that allows quick approval and access to healthcare through each province. And then there's a mode by which Ukrainian nationals can then decide to apply for permanent residency. It's what I call the Angela Merkel model, which is what she used with Syrian nationals in the Syrian crisis, and that's how they inhaled about 900,000 Syrians in less than a year. So if you look at, these are numbers from last year, and if you put them all together, it's actually really astounding. These numbers, we're used to seeing something like 40, 50,000 refugees in a year, and we always take about 20 to 40,000 claimants, half of which are approved. So if you add these numbers together, 2022, nearly 400,000 people that have arrived, and that the refugee health system of the country has to care for. That's many fold more than we're used to in a single year. So I will mute myself and pass it over to Molly to tell you about the difference and then the refugee care issues that we face.
So thinking a little bit about the health of newcomers, again, as we mentioned, there is that distinction between immigrants and refugees. We know that immigrants on average are often actually a little bit healthier than our Canadian population. And the reason for that is that immigrants who are unhealthy are excluded from immigration to Canada. And so we do get what we call this healthy immigrant effect. On the other hand, the health of refugees doesn't really factor into who is accepted or not. And so unhealthy refugees are not excluded. In fact, the most vulnerable and most medically complex are some of those who are chosen by Canada to be resettled. And then in addition to that, we do know that the migration experience and being a refugee in and of itself, it puts you at increased risk of health impacts. And so we know that this is a group of people who have increased health needs, particularly as we compare them to immigrants. As mentioned, there are certain groups that Canada prioritizes. And since 2005, there have been some specific categories that have been kind of the focus of resettlement for Canada. So the ones that, I see in my practice and that we're seeing most often are really women and children who are at risk, the medically complex, as well as survivors of violence and torture. And then there is also always a focus on family reunification. So folks who might have family members here in Canada are also chosen to be resettled here. And, there are a number of social determinants of health that really impact people's health here in Canada and their settlement experience. And so, being in a new country, a lot of the basic things, including education, housing, food security, are really priority areas. And so there are settlement agencies who help assist with some of those basics. That does definitely, though, bleed into some of the health issues that people come in with. And so I think being really mindful of those basic needs needing to be met is important. There are also then navigation issues. So people are learning often a new language, learning how transportation works here in Canada, and trying to navigate really complex social and health systems that are completely foreign to maybe what they have been accustomed to. So all of that does present a challenge sometimes in terms of navigating and accessing health. And then as part of the resettlement, people can also experience things like racism, disillusionment, disappointment in the experience of being resettled. There are also a lot of impacts when families have been separated. Sometimes, part of the family coming to one country, another extended family member going somewhere else, and that can have an impact on health. And there are obviously lots of cultural transitions that people undergo as they come to a new country. So one of the things that I think is just helpful to highlight is what an immigration medical exam is and kind of what we can expect from that and what we should not expect from it. So if you are a refugee and things are moving along smoothly, people will have completed an immigration medical exam before coming to Canada. There are some exceptions to that, when the Afghans were arriving really quickly. Some people didn't have that done before coming and so would get that done here in Canada. These assessments are done by what we call a panel physician. So it's somebody hired by the government and it's a quite standardized process. It has a basic kind of health review, but is most definitely not exhaustive. There are limited investigations ordered, and some of those are highlighted here. So they really are focused on kind of infection screening. And in particular, the focus is on ensuring that people who are coming to Canada don't pose a public health risk. And so that's really what we're trying to identify. So as you can see here, looking for signs of active pulmonary tuberculosis, HIV, syphilis, the urinalysis really is trying to get, possibly a bit of a sense as to whether somebody will, require dialysis or, have increased health needs. But people, even if there are concerns on these results, are not excluded from coming to Canada as a refugee. The important thing again to note here is that the records of those exams, as well as vaccines that are being done ahead of time, and that's kind of a more recent initiative by the Canadian government to have people kind of caught up to date on some of the vaccines that might be recommended. Those records are not routinely received by the post-arrival kind of healthcare providers. So often patients will arrive, say, oh yeah, I did all the testing, I think it was all okay. But really there's often very little way to verify that. And so, we personally kind of consider it a totally blank slate, assuming nothing has been done and just starting again from ground zero. Occasionally you do get a note, but not to really expect that. The one exception to that is that if there are folks who have had a concern, particularly with regards to infection identified on their immigration medical exam, that will be flagged. And these are the people who are required to have follow-up with a healthcare provider once they arrive in Canada. And definitely in our practice, the most common thing is people being identified as likely having latent tuberculosis. And so they are then required to follow up with the tuberculosis team in whatever city they settle in. Usually that's recommended to happen within 2 weeks of arrival in Canada. Sometimes the process can be a little bit delayed. Otherwise, just important to note that there is no expectation that people will receive healthcare once they arrive in Canada. People don't necessarily get screening or anything like that. And so many groups don't receive any healthcare once they've arrived unless they do have one of those public health screens in place. So, there are many challenges to providing care for this patient population. I think a couple of the highlights that I see in my practice are particularly, lots of infectious diseases, chronic medical conditions have often been neglected for a long time. And so we're seeing them at later presentations or with further complications. The other thing, particularly, I think, to an internal medicine crowd, but definitely when we're thinking about adults, are lots of congenital conditions are not diagnosed. And so we need to be thinking about that at kind of a later stage than we would necessarily consider it usually. We, for example, had a patient who was 13 years old, and it was only kind of in the arrival process that it was identified that she had tetralogy of Fallot. And she did really well, but that she had just been living with in a refugee camp without care prior to coming to Canada. And so some of those things that would have definitely been caught in Canada early are important for us to think about. Lots of mental health concerns, severe trauma impact, both the mental health of patients, but also their physical health. And then sometimes we're confused or trying to get more information about medical history and exactly what has taken place before coming to Canada. Recognizing that medical records are often not brought with patients is important as well. And then, from a care delivery perspective, there historically have been some concerns with remuneration during a period of cuts to the interim federal health program back in 2012, 2016. And I think just, structuring care so that it is accessible for these patients is important, recognizing that, with translation services needing to be involved, they can result in long appointments. There's sometimes low health literacy. It's challenging for people to get to appointments on time and navigate exactly what's happening. And so some of those additional challenges and differing expectations with healthcare can impact the care we provide. There are some guidelines that do kind of provide an evidence-based recommendation as to screening and kind of the health welcome for immigrants and refugees. These were published back in 2011 in CMAJ and are the POTI guidelines. And so definitely are a good read, possibly, you know, due for an update soon, but a good read if you're seeing immigrants or refugees who are new to Canada. They outline kind of all of the screening maneuvers that we would recommend and things to consider. A lot of the kind of highlights here include, again, some of the infectious disease screening. There are some notes around kind of mental health, maltreatment, trauma, particular screening with regards to non-communicable diseases, and then women's health. There are also, you know, specifics around vaccine recommendations and things like that, which are all outlined in the guideline. So from an Edmonton kind of specific perspective, you know, I work at the New Canadians Health Centre, and so it is a health center that works in collaboration with a number of settlement agencies and, you know, other health systems in the city to provide care to refugees. Of note, some of the groups that are really important to our work are Catholic Social Services. So they are the settlement agency in Edmonton who have the contract with IRCC to help settle government-assisted refugees. So, you know, helping with housing, education, all of that. Other groups who provide support include the Edmonton Mennonite Center for Newcomers, the Multicultural Health Brokers. And so they are able to provide, you know, counseling and kind of further inform the work that we do. Alberta Health Services, obviously a key player. And then some of the primary care networks. We work most closely with the Edmonton North PCN because a lot of our patients settle in the north of Edmonton. And then the other group to highlight is the Refugee Health Coalition. So that is an advocacy group based in Edmonton, you know, always looking for new members if people are interested in this space. And through their advocacy and work, the New Canadians Health Centre was able to be developed. So a little bit about us. We are a health center opened in August 2021. And really it was the week that we opened was the week that things started to really devolve pretty quickly in Afghanistan. And so we really hit the ground running. We are housed in the basement of Reception House, and Reception House is a small apartment complex that Catholic Social Services owns. And there was a time when it would be able to accommodate all of the government-assisted refugees for their first couple of weeks in Canada as they were kind of finding their permanent housing and things like that. Numbers now are so significant that they're not able to house everybody, but it's a really central spot for government-assisted refugees in Edmonton. So we have the bottom floor there. And we, similar to many other refugee clinics across the country, work as a multidisciplinary primary care transitional clinic. And so with the continuous arrival of new refugees, we are providing care for up to 2 years after people have come to Canada. The thought is that that is a period of time where people are settling into their permanent home, learning language skills, learning kind of the health system and some of the navigation that's required. And that through the work of our health center, we're able to kind of help stabilize some of those medical conditions so that they can then be successfully transitioned to a community family physician and kind of their permanent medical home. Our goal is to serve all refugees coming to Canada, including government-assisted, privately sponsored, and refugee claimants. Again, because of kind of the way things have gone in the past year and a half, there really have been huge numbers of government-assisted refugees. And so we currently only have capacity to see government-assisted refugees, with the hope being that eventually we will be able to expand capacity to the other groups as well. In terms of our structure, we are a team of family physicians working kind of just over a 1.5 FTE. We do have specialist involvements who come work in-house with us and are kind of embedded within our system. That includes 2 pediatricians, a psychiatrist, internal medicine, and then the TB clinic is with us and a key player. We also have other allied health members, nurse practitioners, LPNs, a health navigator. So really, they are in charge of kind of helping people get to appointments, understand the healthcare system, and then obviously our MOAs who help us with all the paperwork. And our goal is really, to help with providing, culturally and linguistically appropriate healthcare, but really also focusing on the successful integration of our patients into the community. And so we do recognize that healthcare delivery is important, but are also always actively working to address kind of that integration. And through that, we do, what many family physicians do, acute medical needs, chronic disease management, mental health, chronic medical conditions, with a real focus on that systems navigation, health literacy, and then trying to successfully transition people to their permanent medical home. In terms of our impact, we currently have a panel of 890 patients, have seen just over 3,300 patient visits in the past year. And we have successfully transitioned nearly 200 patients to a permanent medical home. So it does feel like, there are lots of people still arriving, and we are, always trying to keep up with the number of arrivals. I think in Edmonton, just kind of the government assisted refugees without the additional Afghans or others coming is about 100 people a month. And so it really is a significant number of people to welcome.
Okay. I'll just skip through to make sure we get to the cases. So in Calgary, the refugee clinic, there's probably now the longest continuously active, and it's definitely operationally probably the largest in the country at this point. All similar things to what Molly said, and it's really nice. Actually, we have a great collaboration between the 2 cities and the clinics. Historically, it's just grown and grown and grown over the years. These are some of our numbers, but it's essentially grown to try to meet demand. I did want to save a little bit of time to show you some highlights about some of the research that we do to give you some context about the country. So we are running and recently finished data collection on a CIHR funded study that came out of the Syrian refugee initiative years ago and then interrupted by COVID. But one of the things about refugee healthcare is it's in one of these strange domains where the care lives between federal government that does all the social determinants of health, determines the numbers of refugees coming and where they go, and then the provinces have to do the healthcare. So it's not in the federal government's model. Then there's this jurisdictional awkward dance, like a high school dance, where either tries not to overstep, and it does require a lot more integration and coordination. And so we did a study where we tried to survey the entire refugee health system of the country. And we think that there's somewhere between 60 and 70 refugee clinics across the country in the 10 provinces. This is just a snapshot of what we call the Atlas, which is on our website. And you can zoom all the way in, and it will pinpoint where all the clinics and the resources are in the country with GPS. But just some small pieces that we found were quite interesting, that only 37% of those clinics are dedicated to refugee health, like the 2 in Alberta. Over, I would say, like 70% see a lot of refugees, but some, 10% see some, but not a lot. And then 15% are free care clinics that see refugees and asylum claimants at community health centers, for example, but are not dedicated to it. The populations are very varied as well. So there's a huge variation in how these clinics, and they've been all kind of developed organically across our 13 different health systems. But, you know, over half see relatively small numbers. So, you know, 10, under 250 a year. And then there's only really a few that see really big numbers, like in Edmonton or in Calgary or some of the other larger centers. In terms of capacity, we asked all these refugee care providers what they would estimate were the capacity that they would have at a year. And so somewhere between 9 and 20,000 refugees a year, this system of 62 clinics could manage. And that's, you know, between 10 and 24% of the refugees. But if you include all the others that I showed you, it's a drop in the bucket. It's a tiny fraction of the capacity needed to manage the number of refugees and claimants and evacuees that are here. We asked about coordination and preparation, and you know, this should not surprise people that work in hospitals. Sometimes we have difficulty working across units. You know, when we asked if our refugee clinics coordinate with public health, it was, you know, 20%. If they coordinate routinely with resettlement, 20%. We asked if they actually had communications directly with the government to know how many to get, you know, advance warning of how many refugees are coming and what to prepare for. And, you know, a tiny proportion did. We asked about preparation. And so 42% of these clinics had systems in place. And this is after the Syrian Refugee Initiative, which was a very big resettlement program, largest in 40 years in this country. Only 40% had any standardized protocols since then. About 70% said they were expecting to see Afghans, but 60% felt prepared to do so. And this speaks to, you know, this is in the COVID period. So I think probably speaks to some of the ongoing challenges we've all faced. This is a little bit of a shout out to my grad student who successfully defended his thesis last Thursday, Eric Norrie. He did a study looking at all the upheavals. So refugee health is constant chaos. So after you could extend out March of 2020 from the pandemic and then add the Ukrainian Afghan initiative 2021, Ukrainian initiative 2022, Rohingya probably coming, Sudan. So it's constant humanitarian crisis and upheaval, and the pace is escalating, and it predicted to do so. This just shows you it's an interrupted time series that goes across a decade of appointments per month on the y-axis at the refugee clinic in Calgary, and it just shows you these time periods. So the time period that the interim federal health program was cut, the Syrian Refugee Initiative, we had Yazidi resettlement program, and then COVID. And you can see here that over time, the number of appointments per month has just skyrocketed. So from each time period, it just keeps going up. The biggest jump was we went from about 500 appointments a month to 1,000 during the Syrian period. The slope is the increased number of appointments per month. So we're increasing by 4 per month to 9 more appointments per month. And then after the Syrian initiative, we took 250 Yazidi, which on face of it looked like a small number, but these were the most highly traumatized group we've ever seen. They were enslaved and had survived a genocide at the hands of Daesh in northern Iraq, and it was a huge burden of work. And then went right into COVID, where the numbers have exploded. So over this decade, we've had a 3.6-fold increase in the number of appointments, largely driven by a multidisciplinary team, which had a 15-fold increase due to capacity. As everyone knows, there's only so many physicians to go around. This one is for the trainees that always ask me, well, you know, research is lame and I want to do something that matters. And, you know, all you guys do is research, which is not that helpful. So we do try, I'm a health services researcher, public health researcher. We really do try to inform policy, and we got to move fast because, you know, these crises and these programs get set up within weeks. So this is my partner, medical director, Dr. Coakley, and I in Ottawa after the Yazidi came. And then this is our minister. This is last summer at the airport. We were, as the Western Hub, we were receiving a 747 of Afghan refugees every week, 350 plus that we had across 7 hotels, et cetera. And so we realized, talking to them, they had no information on the health of these folks. So we did a rapid review on the data set, on the data repository we put together. And I'll just go quickly show you some highlights. They are young. So the average age, and this is consistent across refugee groups of all refugees, is in the 20s. If you look at our entire population over a decade, average age is 27. Average age of adults is about 34. The split is about 50-50. You can see here that they come from different countries before they come to Canada. And then always number 3 is Canada. These are babies that are born in Canada after their first 2 years of arrival, which is always our number 3 country of origin. We have different types of claimants. We have a huge barriers to lack of English, because these aren't people that have been studying English to arrive like immigrants. They come without a lot of English training. Oops. And they speak a lot of different languages. And refugee camp exposure, everyone thinks about refugee camps, but this really fits with the international literature. Under 20% of all refugees in the world are actually in refugee camps. The most are dispersed elsewhere. And they make a lot of babies, and the families can be quite big. So this, for the internal medicine crowd, we took all of the conditions of the Afghans, split it up by age group, and then put it into groupings by the ICD-10, which is loosely organized by internal medicine subspecialties. And you can see here that the top 7 of top 8 are generally things we do in internal medicine: infectious disease, endocrinology, MSK, GI stuff. I think we have to have some skin skills still, and hematologic conditions. It doesn't really help though, but when you break it up and then look at the specific entities or diagnoses within these groups, it provides a lot more help. So we always have signs and symptoms like that, this NOS grab bag, and it is always abdominal pain and headache and these types of pain syndromes, which we think are somatoform disorders from manifestations of trauma. And this is ubiquitous across groups. Under the infectious disease umbrella, you start to see, a lot of intestinal parasites, TBI would be under here, lots of other things. Endocrinology, it's oftentimes disorders of nutritional deficiency, more pain syndromes, and then stuff that is, in the wheelhouse of primary care. We then compared our Afghan cohort to our cohorts from across the world, and this is one of the big challenges in refugee health is we stereotype conditions based on region, but really there are conditions. Forced displacement is a negative determinant of health, and there are a lot of shared, the heat map shows the groupings across Afghans, North Africa, et cetera. Oops, shoot, sorry. And you can see that there's a lot of similarities, some differences, so less infectious disease in West Asia, which is the Middle East and the Americas and Europe, but otherwise a lot of similarities across international groups. All right, for the trainees, we did it. You guys I bored you with research and stuff. Okay, this is a patient that called me, sent me this text and said, Dr. Gab, they call me Dr. Gabe or Dr. Gab. I got bit by a mosquito and this happened to my leg. What's the diagnosis? I can't see the chat box, so you have 10 seconds. Okay, you're right. It is a leukocyte. It's a cutaneous leukocytoclastic vasculitis, not a mosquito bite, but he was convinced it was a mosquito bite. What was the cause? Post-strep. So the pearl here is that we really have to suspend judgment in the way people perceive health and healthcare. And how it's interpreted. So you have to, cultural sensitivity training is really, really important. Okay, this is a gentleman who was sent to me in clinic. He's a 40-year-old Syrian man, lovely, lovely man who was sent to me for very stiff back. And when I examined him, he had all of these features on x-ray, and I tried to move his neck, and it was actually, I couldn't move his spine at all. Diagnosis, again, so much better if there's a chat box or trainees that can, oh, okay, good job. Somebody is playing. Anybody? Diagnosis? This one's easy. This is for the R1s. You got this. No? Okay, fine. Severe untreated Angst-Bond. The pearl here is this poor gentleman had, because of migration, and this is a huge issue for internal medicine, is people that were previously well lose the ability to manage chronic diseases. We take for granted these systems that we have in place to manage chronic disease and need routine care. So for 9 years, he had no treatment. By the time I saw him, completely fused spine, tragically, and disability, lots of morbidity due to lack of access to chronic disease care. Okay, this one is one of my faves. I got sent this young man from Eritrea with low platelets, and his platelets 45, his white blood cell count was 2.1, his INR was 1.4, he had splenomegaly on exam, and come on, somebody has to know what this is. We hunt for this all the time. Anybody? This is why Zoom is less good than in person. Somebody? This is one of the unicorns that we love and the trainees hunt for. Nothing. Okay. Ooh. Those are Kaiser Fleischer rings. And this is a young man from Eritrea with Wilson's disease. And it then went on to be an entire saga. He became the first solid organ transplant. Unfortunately, later on, because he didn't, it took a long time to convince him that he was just born with this. There's also a lot of stereotyping that folks from different places in the world may not have some of these congenital diseases. So you got to look for them. They can happen globally. All right. This one's really important. 55-year-old female from Myanmar. She was admitted, had no contact with the refugee clinic. I was just on service in hospital. She was admitted with all the itises due to a new diagnosis of lupus. She was super sick in the ICU, and diagnosis was made. She'd arrived about a year ago. She was a convention refugee, and she's from a minority. So there was no language line, like our telephonic language line. We actually couldn't find. Some dialects are so rare, we actually have a hard time getting translation services. She'd already received 3, hammered with giant doses of Solumedrol and then transferred to the teams where I took over her care. Because she was so sick that she had to start immunosuppression urgently. And there was no medical history available. So this is really important in hospital across multiple subspecialties. Before we smash an immune system to bits, what should we think about? Okay, rhetorical question because no one can answer. So the ICU team was really proud of itself. They're like, we checked for Hep B. She's a chronic carrier. That's important. They checked for Hep C and HIV. They're like, let's do this. Let's blast away. Same rheumatology as well. Anyone else? There's got to be some ID docs somewhere in the crowd. They're like, no, don't do it. Yep. TB. What else? Come on. Come on, ID. You know we love you. Yes, Strangi. What else? Come on, come on. We foreshadowed this like 20 slides ago. Okay, fine. Good job. 2 out of 3. So she was actually, you're right. So strongyloides is super important because it can kill you from hyperinfection. She was strongy positive, schistosomiasis positive. These are long, you could have lifetime infections. It's a really gross but fascinating auto infection cycle in strongy, which we love in refugee health. And schisto copulates nicely in different parts of your body and stays there forever. Latent TB can be turned into active TB, which we've seen. And then just for good measure, she also had a candida infection, which hadn't been treated. So if we had continued to smash her immune system, she probably would have died. And so you must think about chronic parasites and other chronic infections, viral and otherwise, please, before you unleash, immunosuppression, Armageddon. Okay, case 6, this is my favorite. I'll try to go fast. Best case of my life, 46-year-old gentleman came from Somalia. He was sent to me for low back pain and then just like the usual internal medicine, like lots of weird stuff. LFTs were off, he had a high PTH and then he had hypertension. He was on a few things. He was married, had 2 kids, high school education. He was like one of the savviest businessmen I'd ever met. He lived in refugee camps, no drugs, no alcohol. He was ex-heavy smoker. He was born in Somalia, fled to Kenya, lived in Dadaab, which at the time was the world's largest refugee camp, for 5 years, then moved to Kakuma, which is in the northwest corner of Kenya, for 9 years, and then came as a government-sponsored refugee. So when I met him, his primary complaint was pain. He had pain mostly in his back, low back, he said, significantly reduced mobility. He used a cane to walk. He was 46, had a stoop, shuffling gait. He looked really unwell. He said he broke his sacral fracture falling off a motorcycle a couple of years ago. And then his pain was constant, throbbing, aching. Nothing made it better. He couldn't exercise. It went down both his legs. He had a positive skin test at the time. And then he also had shortness of breath and chest pain with exertion, which made me worry. And worse when he said he got upset emotionally. That sounded like angina. There's nothing else. So his occiput wall distance, 8 centimeters. He had pronounced kyphosis. He couldn't extend his neck. Schober's was 0. Couldn't stand unassisted. His cardiac exam was a little bit abnormal, an MGR that was positive, an S4. He had a big liver that I could feel, and this is in the Before I had an ultrasound in my pocket, I was still doing Castells, and it was dull. He was tender all over his axial spine, more on the left than the right, and he had marked loss of range of motion. These were his labs. So some weird cholestatic things with an LD, and he had a PTH that was elevated, and his quantiferon was positive. So I worked on his pain, sent him for an MPI for his angina, worked up his liver and his PTH, just sent him to TB clinic to start LTBI therapy. And he comes back now with polyarthritis, small hands, joints, all his other smaller joints. He's talking about morning stiffness. The MPI came back negative. Thankfully, his PTH was still elevated. ALP was high, which was odd. And ultrasounded, his biliary tree was fine. Pain, now he mentions, yeah, it's probably been getting worse for 10 years straight, doc. So what do I think? This is my differential at that point. I'm thinking this is going to be another seronegative spondyloarthropathy, probably maybe POTS we've seen many times. Seronegative, I was, really going down the MSK route. HLA was negative, ESR CRP negative, autoantibodies negative. So I ordered the MRI. Let's see if we could find some SI joint inflammation or elsewhere. And then I thought, we better check his bone density because his PTH is chronically elevated. He probably has very, very fragile bones. And then I get this call from an old classmate in med school. There's no evidence, this is the MRI, there's no evidence of discitis, but his whole bone marrow is lit up like a Christmas tree. It looks weird and something infiltrative. I have never seen anything like this before. And I was like, oh, okay. His DEXA scan comes back and he's got bones like Wolverine. His Z score, and these are standard deviations, 4 and 9 times higher than normal. So what is going on? I don't know, but I admit him to myself back when we used to be able to. We do a bone marrow and a bone biopsy. It's a dry tap. We send off the bone biopsy. He's got diffuse osteosclerosis, and he's still hypophosphatemic all the time. His urine, do 24-hour urines. His urinary calcium is low, and his phosphate's inappropriately normal. Sorry, I'm going fast. So I sent him to a super smart endocrinologist, Dr. Klein, who was one of my preceptors and brilliant and a lovely man and a good friend. I'm talking to him on the phone. He's like, this is going to be congenital or acquired. He was saying, oh yeah, my son also has pain. So I think, this is going to be congenital. Osteopetrosis, I've seen this before, very rare. Acquired, so I'm like, Greg, just for my own education, can you teach me what are the acquired forms? He's like, oh, they're super rare. You're not going to see them. Industrial toxin exposures, fluoride exposures, etc. And so I'm talking to Doc Anna Lee, who's his family doc. And she says, I was in Kakuma last year and I met this crazy geologist who lives in Calgary, but he said, don't drink the water because it's toxic with heavy levels or high levels of fluoride. And we were like, holy crap. So we send him for an open bone biopsy with tetracycline labeling. And at this point, we're thinking if he has it, there's 200,000 people in that camp. We send him for histomorphometry at the Mayo Clinic. And then as you do, oftentimes we send a piece of bone to a dental research lab in Augusta, Georgia for direct fluoride measurement. Meanwhile, I meet Paul and I learn about Kakuma. It's in the Rift Valley. It's the third largest camp in 2016. It has about 200,000 inhabitants. It's much bigger now. It's in the desert, and it is 100% dependent on 15 wells for its potable water. It's in the volcanic rock down in the deposits have very high levels of fluoride, and they knew that there was high levels of fluoride in the water, but there were no severe health issues that have been reported to date. So then I introduced Paul to the patient. We hang out together. We roll out a map of Kakuma and say, where did you live? And he said, I live here in block 2. And then we find all the boreholes, and Paul, who was actually working on this problem, said he had well water data about the fluoride measurement concentrations in these wells. We get it down to, we locate it down to borehole number 5, which feeds the entire block 2. Months later, we get this direct bone measurement that shows that he has 7 times the normal level of fluoride in the bone. So that's the red hot smoking gun diagnosis. It took 2 years. Severe skeletal fluorosis. Here's the camp. And if any of you do public health and know the John Snow story, this is borehole number 5. This is block 2 where he lived. So we send it back to UN, to UNHCR, WASH is the water and hygiene folks, and I thought for sure they were going to bury it, and thankfully they didn't. So they used Paul's new drilling technique, which he was experimenting on, that was a lot safer. Fix the water supply for the entire camp, and 2 further, and then published a case report in the Lancet, which they haven't done in 10 years, and it's the best case of all time. Okay, resources, because I'm sorry, we're running out of time. RefugeeHealthYYC.ca, we have a whole page for clinicians. There's lots of stuff there. There's an app if you need billing, there's checklists, there's lab recs, there's information about all the things that we see. Oh, sorry, that's the phone number for the New Canadian Center. If you are a trainee or if you're really interested in this field, this report just came out last year. It's the World Report on by the WHO, came out in July. It's very good, comprehensive. It can give you a good overview of migration health issues. If you're interested and you're seeing Ukrainian evacuees, a couple colleagues and I published a paper in CMAJ in July, also kind of overview of what we know about the health of Ukrainian population. Here are your health resources in Edmonton, which Molly will be happy to give to you and disseminate afterwards. I'm just going to finish. These are your pearls, which we already went through. Okay, tips. Must use interpreters. Please don't use kids and family. Everyone has language line. It is the gold standard. Work is slow. Don't expect regular appointments. Trust and rapport fundamentals. Set it first. You must have cultural competency training if you're going to do this work. You must have extra training in trauma-informed care and mental health, because it's everything we do. Be aware of vicarious trauma. As we learn the hard way, you can be traumatized by people that tell you about horrible things. Healthcare navigation literacy. If you can centralize and work through your refugee clinic or friends, it's helpful. IFH billing is not hard. We can help you. NHC is here for you at all times. And the last thing I want to say, for the first time ever, we are hosting the North American Refugee Health Conference in Calgary. It's biannual, Canada, US, Canada, US. It's never been hosted outside of Toronto, but because Alberta is the best, we actually, little known fact, Calgary has resettled more refugees by itself than the entirety of BC and Edmonton almost. We resettle more refugees per capita than any other province, than 2 cities in the country. We're very, very good at this. We're excited, we're working hard. So please come if you can, send your trainees if you can't, and you can buy a ticket for a trainee or a refugee or resettlement worker. And we're done. Oh, and this is a tribute to Paul Farmer, who's a giant in our field and I had the fortune of studying under, who died suddenly last year, which is a huge loss to the global health community. And those are our emails. And I apologize, I left not enough time.
That's fantastic. Thank you, Molly and Gabe. Such important information. And we do see these patients, right? In multiple venues, like you said, inpatient, outpatient, so on. So just to have that approach and those cool cases was really nice. There's a question in the Q&A that I'll just read out. Great presentation, thank you. Sorry if I missed this in the talk. How can we refer to the New Canadians Health Center? I wanted to refer someone and called, but the admin said they didn't know how patients are referred. They took my pager number so someone could call me, but I didn't get a call back. Sent a referral letter, but the patient didn't get seen and I didn't hear back. Any tips would be appreciated.
So Lindsay, that's a great question. So what's interesting is that because we are so far only seeing government assisted refugees, and we're only seeing people who've arrived within the past 2 years, because we work in the same building as Catholic Social Services, we actually have the list of all of those patients. So we know who is a government assisted refugee and who would kind of fit our mandate. Sometimes there are people who, are super sick, end up in hospital, like right off the plane. And so they might not have connected with us. Those would be the perfect patients for us to see. And we're always happy to, get a phone call to help figure things out. I'm definitely probably one of the people who's there the most. So feel free to send me an email or give us a call. I think we were initially getting some referrals that were for privately sponsored refugees or folks who had maybe been in the country a lot longer. And so we just don't have capacity to serve them at the moment. But we are always looking to smooth out our pathways to things. And so if you do have feedback from, the inpatient setting or whatever kind of specialty you're working in, please provide that. And I would be most happy to get an email, but definitely sending us a fax, sending an email or a call is a great way to get in touch with us to see if we could see that patient.
Thanks, Molly. And what we'll do is we'll make sure that all the links are available. I think we have recorded this, so with the recording, we'll make sure that those resources are available. So on behalf of the department, thank you to both of you for this really informative and fun, actually, in a lot of ways, talk, especially towards the end there. Some things to add to our annual Medical Jeopardy. So thank you and have a wonderful day. Take care.